Hey, welcome everybody to our talk. I'm really glad you took the opportunity to spend some time this afternoon. We're going to get a lot of information out to you guys over the course of about a half an hour. And for some of you, it's going to be sort of a review of what things you may already know about atrial fibrillation. And for others, it might be a lot of new stuff. But regardless, I hope to reinforce some important aspects of not only the diagnosis, but how we treat it and how we lower the risk of things. Here are the goals for this particular presentation. It's a brief overview of atrial fibrillation causes and symptoms. We'll talk about the stroke risk associated with atrial fibrillation. We'll talk about some advanced treatment options for AFib, including ablation, which is very popular, and the Watchman procedure, which is becoming increasingly well known. We'll talk basics about how the heart works in the electrical system, the connection between atrial fibrillation and stroke risk, and provide you some educational resources, as well as access to the VCS arrhythmia physicians called electrophysiologists. So what I'm going to discuss may be subject to some regulatory approval. And so from a technical standpoint, some of the labeling may change. It's probably not very applicable to this presentation. The opinions are my opinions based on my experience and my training. And hopefully that counts for a lot at this point, since I've been doing this for a little over 20 years. And here I am. I'm Dr. Charles Joyner. I have several partners in this group as well. I've been with Virginia Cardiovascular Specialists for about 18 years. My primary office is here at Stony Point, where I am right now, but I also go to two other offices. Over on 360, the Harborside office, and down in Colonial Heights, we have the Waterside office. You got my education there and the aspects of my practice that I specialize in. And you'll see everything from pacemakers and defibrillators to ablations, and then Watchman device implants. So how the heart works, again, for some of you, a review, for some of you, a little bit more on the new side, but basically you've got four chambers of your heart. The top chambers are called the atria, and the bottom chambers are called the ventricles. The ventricles are larger. The right ventricle pumps blood to your lungs, and the left ventricle, which is more muscular, is what sends blood to your body, your brain and your body. So that's the big pumping chamber. Above those, you've got the atria, and these are the chambers that receive blood and then deliver them to the ventricles, or deliver it to the ventricles through these valves. The important part for today is that atrial fibrillation typically originates in this chamber called the left atrium. Less frequently, there are some drivers of atrial fibrillation in the right atrium. And as we get through the talk, you'll see that these little openings here are very important to us when we talk about treating AFib with ablation. This is where the pulmonary veins bring oxygenated blood from the lungs back to the heart, and they enter right here. As you'll hear later, as it turns out, there's a lot of electrical activity right in these areas that seems to promote atrial fibrillation in a very significant way. So let's see, these videos may be a little bit hard to see, but we'll give them a try. So what is AFib? And you can see the difference. Actually, I'll just describe this one. We won't worry about playing this one. Here's a normal heart rhythm strip, and here is the irregularity that is the hallmark of atrial fibrillation. And these are just the manifestations we see on tracings. But what goes on in the heart is that in this case, you've got this uniform heartbeat. The signal begins up here in the top, proceeds down the center, and then the signal gets distributed to the rest of the heart. In AFib, there's very chaotic electrical activity. And you can see these little stars or asterisks, flashes, whatever you want to call them, that signify that a lot of the abnormal drivers are here at the pulmonary veins. And all this stuff is firing kind of at the same time, very chaotic, and it gives you this irregular heart rhythm. And it leaves the ventricles unable to communicate in a sequential manner with the atria. So they're not really talking to each other very clearly here. We'll give this one a try. I'm not sure it's going to work or not, but let's see if I can pull it off. So this is normal heart beating. Everything is in sequence here. And then you'll see the rhythm will start to change. This is normal rhythm, but here's irregular rhythm starting to come along, and you'll see chaotic electrical activity. You'll see things beating in different sequence. And that is really the hallmark of AFib. Let's see if we can move it along. Here we go. So atrial fibrillation is really common. Every day in the hospital and in my practice, I'm seeing somebody with atrial fibrillation, in fact, several people, and the numbers are increasing. You can see we're at this upswing where we have over 5 million people with atrial fibrillation in the United States. And it is estimated by the year 2050, you might have up to 12 million Americans affected by atrial fibrillation. So bad for people in terms of incidence of atrial fibrillation and symptoms. Also, it impacts the quality of your life, and it's expensive. You can imagine that something that affects 12 million people does put a burden on the healthcare system. So it's an individual problem and a societal problem that we need to find the optimal ways to treat. There are categories we refer to when it comes to AFib. AFib is not necessarily a continuous issue. In fact, in most people, it starts in an intermittent fashion, paroxysmal, which means it comes and goes on its own. You don't really do anything as an individual that starts it, and it just stops without any particular intervention. Persistent refers to atrial fibrillation that continues for at least 1 week, and it can go ahead and become something more long-standing or ultimately permanent. So persistent AFib doesn't go away on its own. It's something we have to work on. We have to do something actively to restore normal rhythm in that kind of a case. And then you've got the final category, permanent. And permanent is described as, permanent's described in very different ways by lots of people, but I think clinically speaking, it means you are continuously in AFib, and furthermore, that it's really difficult at that point to restore normal rhythm. There may be no good way to restore normal rhythm. At a minimum, it will take a lot of effort to restore normal rhythm for somebody who has permanent atrial fibrillation. What causes it? So one of the things that I get asked many times, and even today, you know, doctor, tell me when my AFib started because I want to know what I was doing at that time. Most of the time, it's nothing that you're doing. In most cases, it's the culmination of a number of things, age being the most predominant factor, hypertension being a very preeminent independent risk factor. You got some other things like structural heart disease. So when people have valve problems, heart enlargement, scar tissue from heart attacks or viral infections that affect the heart, all of these things, even believe it, coronavirus seems to have some ability to cause people to go into atrial fibrillation. Then you've got some other things that aren't clearly identified. You've got some genetic factors that may play a role, especially if you develop AFib at a younger age. People who are these premier athletes who are always exercising to tremendous degrees, triathletes, Ironman people, marathon runners, their heart undergoes changes which are healthy in a lot of ways, but sometimes do lend themselves to atrial fibrillation. And alcohol consumption usually in this case refers not just 1 drink a day or your red wine or something like that, but heavy alcohol use does clearly have an association with AFib, and certainly binge drinking like people would do on New Year's Eve. We call it holiday heart, seems to throw people into AFib with some frequency. Signs and symptoms. I'll put all these up here. So I think it runs the spectrum. You'll see in this blue individual over here, there can actually be no symptoms at all with AFib. And while this is good from a standpoint of how a patient feels, it's a little bit dangerous because that means you can have AFib and be undergoing the other risks, especially stroke risk of AFib, but you might not know you have it. Now that's not extremely common, but it's, you know, I'd say 1 in 10, 2 in 10 may have no symptoms at all. I think of the things listed here, the most specific symptom would be a racing heart, a fluttering sensation in the chest. People would call them palpitations. Usually when people mention this, it's almost always some kind of an arrhythmia. It doesn't have to be AFib, but it means usually it's more specifically related to arrhythmia rather than the multitude of other causes. And I even added that especially if these symptoms come and go abruptly. So if someone said that, you know, for 2 hours, I felt this pounding and racing, and then it just all of a sudden went away, that's very characteristic of a heart problem. Shortness of breath can be caused by any number of issues. So it's not a specific symptom, but certainly Exertional shortness of breath can be associated with AFib. Fatigue can be associated with AFib. I think this is, again, non-specific because dizziness can be so many things. Hell, it could be a sinus problem. It could be a middle ear problem. It could be low blood pressure. So when you have this, this doesn't necessarily mean AFib, but I think what you can appreciate on this slide is that all kinds of symptoms or even a lack of symptoms may be associated. AFib and stroke risk. I would imagine most of you guys realize that there is a stroke problem that's clearly associated with AFib. And in fact, it might be that the majority of strokes in our population might relate to AFib more than anything else. If people with AFib are certainly at greater risk for stroke than people who carry normal heart rhythms. AFib is not the only risk factor for stroke, but it's perhaps the most predominant one. And when you have AFib, it increases your stroke risk by 5 times. So nobody wants a stroke. Strokes are debilitating even if you survive them. And AFib-related strokes can be some of the larger strokes and most debilitating ones out there. So there's a high priority of trying to find a way to minimize the stroke risk. So why does atrial fibrillation matter? And this is an extension of what we've already discussed, but it can put you at risk for other complications. Blood clots that can form in the heart, specifically this corner of the left atrium called the left atrial appendage, and I'll show you a picture of that later. If that clot breaks away and enters the circulation that goes to the brain, it can cause a stroke. And then there's some other things that can be associated with atrial fibrillation and the dysfunction of the heart itself. AFib that continues over a long period of time decreases the heart's pumping efficiency and can lead to heart failure. Heart failure in this case meaning the symptoms associated with pumping failure of the heart, fluid retention, shortness of breath, and that sort of a thing. Let's see if we can make this one work. Videos are always a bit of a crapshoot on these things. Let me see if I can find it here for you. We'll see if I can.
Atrial fibrillation, AF, is a heart arrhythmia in which abnormal electrical signals begin in the atria, top chambers of the heart. The heartbeat will be irregular and faster than normal. AF can put you at risk for other complications, including blood clots, stroke, and heart failure. In atrial fibrillation, the atria do not achieve a solid contraction, which means blood may not be fully emptied from the chamber. This can lead to blood pooling, and blood clots may form. A blood clot in the heart can travel to the brain and cause a stroke. Atrial fibrillation is associated with an increased risk for stroke. If atrial fibrillation continues over a long period of time, the decreased efficiency of the heart can lead to heart failure. Heart failure is the long-term inability of the heart to pump enough blood for the body's needs, and the body's organs don't receive the oxygen they need to work properly. It is important that AF be converted to sinus rhythm or controlled.
Okay. Let's see if I can somehow get back to. Oh, that's pretty impressive that I was able. Actually, it's lucky that I'm able to get back to this. Okay. Did you know approximately 1 in 3 people with AFib will have a stroke in their lifetime? And I think this is based on untreated patients. More than 90% of stroke-causing clots that come from the heart originate in the heart, especially in this area called the left atrial appendage. And AFib-related strokes are frequently the most fatal and disabling of all strokes. Here's a little bit of an acronym. We in medicine always have acronyms. I think there's so many it can actually make it easy to forget these. But many people, I think, know this about strokes, things that can acutely be affected. Your balance, your vision. You can have asymmetry of your face, drooping of half your face, weakness in a limb, clumsiness in your hand. Your speech gets affected. And then if any of these show up and they're acute symptoms, these are not the kinds of things you would wait on. These are the ones you call 911 for, because even strokes, when they've happened, if you get to treatment in time, can be helped tremendously, and some of those symptoms even completely reversed. So much like we treat heart attacks now, the faster you get to the hospital, the better we can assess and intervene. Treatment options. So very broadly speaking, once an atrial fibrillation diagnosis is established, you've got two distinct management pathways. Up front, reducing the risk of stroke. So don't be surprised if the discussion literally begins with reducing the risk of stroke, because this is something that needs to happen now and usually remain an ongoing management protocol. Most people get oral anticoagulation medications. We'll specify some of those a little bit later. And nowadays, under the right circumstances and with the right indications, you can undergo left atrial appendage closure. In terms of the arrhythmia itself, of managing atrial fibrillations, we can manage the rhythm and the rate with medications. This means rhythm means we can help you get back and stay in normal rhythm with certain medicines. Rate of atrial fibrillation can also be controlled with medications. And there's some classic ones that we use for rate control, what we call beta blockers, calcium channel blockers, things like metoprolol and diltiazem. We can do procedures to try to eliminate or sharply reduce atrial fibrillation, and that's called ablation. And then, of course, going back to that previous slide where we looked at the influences on AFib, there are some lifestyle changes, and that might be things like reducing your alcohol intake, treating sleep apnea if you have it and it's untreated, sometimes reducing stress. There are some other things that are more extreme behavioral problems, drug use, cocaine can be associated, but I would imagine most of us in this talk have no issue with that. But it just shows you there are some things that can be adjusted from a lifestyle standpoint that make atrial fibrillation easy to treat. I didn't put it here, but maybe somewhat connected to lifestyle changes. When obesity is a big problem, it is harder to treat and eliminate atrial fibrillation. So sometimes when somebody is morbidly obese or markedly obese, sometimes I will ask them to put forth their biggest effort at reducing their obesity as a means of helping treat atrial fibrillation among all the other benefits of weight loss. So rate control, meaning control the rate of the AFib, so it's not running your heart too fast. Rhythm control is trying to restore normal rhythm. We talked a little bit about this. And then we've got the ablation procedures and things we do to get back and keep normal rhythm. And also we'll discuss how we monitor AFib. Again, sometimes you feel the AFib, sometimes you don't. There's a real premium on knowing whether you're in it and for how long you're in AFib. So we'll talk about how we monitor that. Now, I'll see if this will work. It may be hard to get this one, but this is a video I did years ago to educate my patients on atrial fibrillation ablation.
A discussion about atrial fibrillation ablation is one of the most common ones that I have with patients these days. Broadly speaking, what it means is that we put catheters into the heart with the goal of finding the areas that trigger and continue your atrial fibrillation. When we find them, we try to cauterize or freeze those areas, thereby maintaining normal rhythm and making you feel better. Technically, an atrial fibrillation ablation involves the patient coming into the lab, being placed on a breathing machine and attended by anesthesia staff, so you don't feel anything during this case. Then a doctor like myself, a cardiac electrophysiologist, will come in and place catheters, usually at the veins at the top of the leg and maybe one up by the collarbone. Our catheters are like soft wires. They're guided up to the heart, and we create a sort of a three-dimensional electrical picture of your heart and its electrical components. Most atrial fibrillation is caused by problems in the left atrium, so we put our catheters there, find the areas that cause the problem, which usually are the pulmonary veins and other associated structures, and then we use our catheters to freeze or cauterize those areas, and that tends to stop the AFib and keep it from coming back in the majority of cases. The success rate of an atrial fibrillation ablation tends.
Okay, hopefully everybody can hear me again. We're back on the regular talk, and I use that video because the graphics in it really show us the anatomy and how our catheters are positioned in the heart. And it's obviously not the exact thing we would see during a case, but I think it depicts it quite well. In that video, I go on to talk about the success rates of AFib. As one might imagine, it varies with the degree of the chronicity of the atrial fibrillation you have, your age, other heart-related structural changes. But going into most AFib ablations, I think we're looking at something in the 70-75% success range, which is not great, but it's actually good for such a broad, very different arrhythmia that's unique to the individual. And the other thing I mentioned is that one AFib ablation may not be enough for great control over the course of years. There's a repeat procedure frequency of maybe 15 to 20%, which we're trying to improve upon that. But again, this is a condition we manage in people. Pure eradication may not be what we achieve in everybody, but we certainly can make most people better. So I put up in terms of monitoring, when you know you have atrial fibrillation, but you're trying to figure out exactly how many recurrences, how long the recurrences last, when we're taking an intervention like medicines or an ablation, and we want to follow that up to see how much we've reduced the AFib. We either have the monitors that we can send out of our office for people to wear, called event recorders or Holter monitors. But some people, and in fact, increasingly numbers of our patients have these consumer-based devices. You'll see commercials for these things. Of course, this is the Apple Watch, which has become very sophisticated at showing you and labeling your heart rhythm. This watch can actually show you on your smartphone through a bigger screen what it's saying, and it actually can label AFib. As does this one, which you might see advertised more around the holidays, called Cardio Mobile. Cardio Mobile is essentially this pad where you put your fingers and it works with your smartphone and you can get a heart tracing. It usually is pretty good at making a diagnosis. It's not perfect, but it's pretty impressive. And I think the price of this is still usually running in the $89 range, which for something that's yours forever is not too bad. Not too bad. In the office, our monitoring has become much more sophisticated as well. And we have these devices called implantable loop recorders, which maybe you can get an idea by that right-sided image where you see someone holding it here. This is about the size of a clip on your pen. It's not very big at all, but it houses a lot of technology and a battery that will usually let it last up to 3 years. It's injected under the skin with a little numbing medication about right here. And some people use a suture. I usually use one suture. Some people don't use a suture at all. But that takes about 5 minutes to put it in. And this thing is always on. It can record any heart rhythm that's of any significance. It can convey it to a little smartphone that comes with it so you can see what it is and you can send it to your doctor. So again, for 3 years, we have very intense monitoring of your heart rhythm. This is more and more being utilized by doctors and patients to see when they have AFib. Really impressive when people have asymptomatic AFib, because obviously they won't be able to tell us much about when they have their recurrences. Now, the big talk these days is not only about ablation, which we've been doing now for, I guess in a broad sense, for maybe 12 or 15 years, but certainly never more than now. But the other thing we can do now is find other ways to control stroke risk. We have new medicines and we have new technology. Treatment options include the oral blood thinners or procedures that block off or close this corner of the heart called the left atrial appendage. This little ridged outcropping of the left atrium is where the blood is most stagnant, and this is where most clots form. This device comes compressed in a tube, and we expand it right there, and it's supposed to go completely across that dimension, that diameter, and keep clots from coming out. It stays there permanently once we put it in. Common blood thinners, most people have heard of warfarin. This has been around for decades. It works, but it's somewhat variable in its effect. You have to be careful with what you're eating so it doesn't throw off the dosing of warfarin. You need lab work approximately once a month on warfarin. The newer blood thinners, Eliquis, Pradaxa, Xarelto, and Savasa, are the new blood thinners that are designed primarily, in our case, to prevent stroke. They do not require routine lab checks, and they actually are studied to be as effective as warfarin, perhaps even better in some safety aspects. In most cases, people can take blood thinners for years without any serious side effects, but some people do have bleeding issues on them, and there's always a bleeding risk when you take a blood thinner. I added that importantly, I get asked this a lot about aspirin and things like Plavix being sort of a strong form of aspirin. Is that enough at preventing strokes from atrial fibrillation? And the truth is they really don't compete well at all against these others. So this is usually not the recommendation. Now, if you can't take these and you can take this combination, this will reduce your stroke risk a little bit, but these are not considered equals. So that's why you'll see your doctors pushing for these other medicines and not settling on aspirin or Plavix for these circumstances. As mentioned just before, because blood thinners help by preventing clots and thinning the blood, inevitably your risk of bleeding will go up. You're always weighing, and it depends on your own risk factors, your risk of stroke versus your risk of a serious bleed. As you require or acquire risk factors, age, prior stroke, heart conditions like heart failure, diabetes, hypertension, as you acquire these risks, your risk of stroke goes up, and the more you need something done, usually a blood thinner. A little bit more depiction of the Watchman devices. This actually is the Watchman device we started with, and this is the one that was studied and led to its approval. We are now mostly putting in this version of it, which is proven a little bit easier to place, can be utilized in more variable sizes and shapes of the left atrial appendage. It feels safer to me. I think over time we'll determine if it's actually safer than its predecessor, but it's certainly in most of the hands of the implanters, they feel a lot more comfortable implanting this one. So I'm very happy that nowadays when you come, if you come to see me for Watchman, you'll be getting the newer unit called the Watchman Flex. So Watchman usually is a very lengthy discussion, but I think this will be a nice introduction to it. It's a one-time procedure that may reduce stroke over a lifetime, just like blood thinners would if you could take them for a long time and consistently. It is as effective at reducing stroke as warfarin. But unlike warfarin, the Watchman implant reduces the risk of long-term bleeding because essentially, once we put this Watchman in, 6 weeks later, we verify that it's properly positioned, and that's when we usually stop the blood thinner. So the vast majority of people, 95+%, stop their blood thinner 6 weeks after Watchman implant for good. It doesn't require open heart surgery. It's nothing that can be seen outside the body. It has no battery or electronics. We do it under general anesthesia. It takes about an hour or maybe less than an hour. It used to take longer when we were first putting these in. Actually, most of our patients, I think 60 to 70%, are going home the very same day after a Watchman implant. If you are done late in the day or you have some issues related to your sedation or don't feel comfortable, we will keep you overnight. But with the coronavirus pandemic and our desire, along with the patient's desire to get out of the hospital as soon as possible, we've learned different techniques to make that safe. And that's actually worked pretty well. I think most people like getting home, if that goes without saying. Again, maybe a little bit better anatomical picture. It's performed in a cath lab or preferably for us, the electrophysiology lab. It doesn't need surgery. We have a specialized team that does this, and our representatives from the company that makes it, which is Boston Scientific. Primarily, we put 2 catheters or small tubes in the veins at the top of the leg called the femoral veins. When we're done, we remove those and we seal them up so the bleeding stops. Again, general anesthesia, you're completely asleep. It's a 1-hour procedure. This is no longer true for most people. Most people go home same day. And I just mentioned this, that 6 weeks after Watchman implant, 9 out of 10 people were able to stop warfarin in the clinical trial. And that's warfarin or whatever blood thinner you're on. So if you come and you're on Xarelto now, or Eliquis, or Savase, or Pradaxa, we're usually able to stop that at 45 days. People love that moment. Watchman had to go extensive studies. So this is nothing that came out. It's not like our vaccine that was able to come out very fast. The government made Watchman really prove itself, the FDA. So it took 10 years for it to go from its original studies to approval. And from a patient and doctor standpoint, that should give you some confidence that it was looked at extremely hard before approved. And that gave me a comfort level. And better than that is that after approved and after we started putting these in, the subsequent information as we followed this patient seemed to verify and bear out how good this was and how safe this procedure was, or is. Proven safety record. Now more than 150,000 people have received the Watchman implant. That should say 150,000 around the world. It still has a great safety record in the post-approval studies that we do. Now, who gets one? Not everybody gets one. And this may be a little late to introduce this into the talk, but all you guys on blood thinners, maybe just starting or for years, of course, you'd love to be off the blood thinner. But currently in the United States, the indication is that you have to have AFib that's not caused by some major heart valve problem. That would be the case for most of you. And you have to have some significant issue with taking the blood thinner over the long run. So you've experienced significant bleeding, which makes us scared to use the blood thinner. You've got some other problem related to the use of it, like extensive bruising, or you have some lifestyle or job-related conditions that put you at risk for bleeding. So this may seem like sort of tight criteria. They're actually not that strict. There's a lot of different things people can have that fall under the umbrella of long-term risk of ongoing use of blood thinners. So a lot of people come my way with a multitude of reasons why. Now, things that don't count really that much, you can't because you just say, I don't like taking blood thinner. That's probably not enough reason to undergo this procedure. Unfortunately,
thank you.
Expensive medicines is not the reason to go for a Watchman. You know, Watchman is not cheap compared. This is a procedure under general anesthesia, so you're not saving a lot of money, broadly speaking, by opting for the procedure. I can see why an individual from an out-of-pocket concern might think of that, but that's usually not a reason to get a Watchman. And this is one to be kind of interpreted carefully. People who should not be considered for Watchman. In our country, if you absolutely can't take a blood thinner, aspirin or Plavix, we're not really supposed to consider you, but I believe it is true that most of us are now adopting a bit of a European aspect of this. And if you can take something around the period of time where we implant the Watchman, we're willing to do it. But there has been a requirement, and I think it's for safety purposes, that once we put this thing in, there is a period of time that it's a little bit more prothrombotic, or what we say, there's a little bit of a tendency to get clots around the brand new device. And if you use a blood thinner temporarily, that helps with that. So we actually like using these medications at the time of implant and for the first few weeks. If someone just cannot take any blood thinner whatsoever, it makes it a little bit more difficult to go through the process. Of course, if you have an allergy to some of the metal, like nickel or titanium, we have to be careful about putting it in or have to avoid it. We get pictures of the left atrial appendage ahead of time to get an idea of its depth and its width, because not every Watchman, there's 5 sizes, but not every Watchman fits everybody out there. And we can't leave one in place that's malpositioned or not fitting properly. And then finally, if you're taking blood thinners for something other than AFib, you're not going to be able to stop the blood thinner anyway. So let's say you have a problem with a hematologic problem. Your blood tends to clot more for genetic reasons. Well, putting that Watchman may stop clots from coming out of the heart, but it doesn't stop the clots that develop elsewhere. So you're still going to be stuck taking a blood thinner, and for good reason. So let me sort of close out things by showing you how our team has expanded over the years. Up top, you'll see pictures of when our hair was a little bit darker. This is when we were starting AFib ablations. Me and Dr. Gilligan, Dr. Onifer had a lot of experience when he came and joined us in the group. And now we have all these other gentlemen who all do atrial fibrillation ablations in our group. Dr. Bowie, Dr. Master, Dr. Schneider, and Dr. Sani. So we have a lot of people doing AFib ablations, a lot of people doing Watchman implants. And let me tell you that it's necessary because the population and the incidence of AFib has increased to that degree that even with this number, we're working every day at a high pace to keep up with things. So it's amazing how this has expanded over the years. And I'm going to go ahead and end our talk there. That was really the scope we wanted to cover. And we're looking, I see a few things on the chat line. Let me see if there's something that would make sense for me to answer for the group as a whole. Sometimes individual stories can be a little bit difficult to cover in a group setting, but let's see here. I think this is a great question. Should I delay an AFib procedure due to COVID-19? As many of you might remember, there was a period of time in the late spring when they sort of put a moratorium on elective procedures. So AFib ablations are usually done under controlled circumstances. They're long-term treatments. They're not acute treatments. You don't come to the ER, show yourself to be an AFib, and then get booked for an ablation a day or two later. That's usually not the case. Usually this is someone who's already in AFib, who's in most cases has tried a medicine to control it that hasn't worked. A few months have gone by, or maybe years in certain cases, and then we decide we need to step it up and do an ablation. So it's usually an elective procedure booked maybe within 1 to 3 or 4 weeks after we see you in the office. Now, that having been said, we are and have been able to do lots of procedures in the hospital from the summer onward. We're very proactive about testing people before they come in to make sure that you're not COVID positive before you come. We don't want people causing infections to the other patients and the lab staff, nor do we want the staff to cause problems for the patients. And this process has worked out extremely well. So I don't think, broadly speaking, you need to delay. If you have had COVID or you test positive, we will ask you to delay until you've either completely gotten past the infection or at least past your quarantine period. Let me see the next message here. I have read from the company that makes the device, the Watchman is 90% effective, still a significant risk for stroke. So I'm not sure about where this is pulled from. I don't doubt that there's something on the site that says that. In truth, I think the better way to look at this is our standard bearer for stroke risk reduction would be warfarin. That's been used for years. And we know that we have very few strokes if you are appropriately treated on warfarin. We also have very few strokes. I mean, when I say very few, I'm a doctor who sees a lot of patients. I can probably count on less than one hand the number of people that have had a stroke on proper therapy, proper blood thinner. So if the Watchman device matches that, that's pretty good. So 90% effective. Remember, your chance isn't 100% of having a stroke, even if we do nothing. So you're starting with single-digit risk, 5% risk, 10% risk as an individual. Something that comes along that's 90% effective will really cut your individual risk down a lot. And remember, the counterbalance of this, or the extension of this, is your stroke risk goes down dramatically. Your bleeding risk goes down precipitously because you're no longer on a blood thinner. So both stroke risk and bleeding risk go down after successful Watchman implant. Let's see. During an ablation procedure, how does the surgeon see what you're doing since the heart is still beating? We create three-dimensional computer images of the heart, even while it's beating. Our catheters have the ability to sense when they're within contact of the tissue within the heart. We even have force sensing measurements to tell us what we're doing. And of course, we have a feel for these things. So our catheters are soft. They're not like a stiff rod or a coat hanger, so they can bend and flex even with the heart movement. So between our three-dimensional computer-generated geometry and these things we can see and feel and sense on these catheters, it's actually not that difficult. Excuse me. Here's something of an individual question. I'll ask the question. I won't know the details enough. I recently had an open heart surgery, a maze procedure, which is often considered the way the surgeons do ablations. It's a little different than ours. The doctor discontinued the blood thinner. He wants to know, is that safe? Unfortunately, I can't answer that question. I don't have nearly enough information to know. So I unfortunately can't answer that one. I wish I could. The doctor that discontinued the blood thinner should be very aware of what they did and why. So I can't answer for you whether that was the right decision or not. I think you'll have to go to that individual doctor. Good question here. How do you confirm after 45 days that the Watchman is working? Well, the Watchman's job is to sit there and block the appendage. So if it hasn't moved compared to the position we left it in, and if we don't see any leakage of blood around the Watchman, either going in or out of the left atrial appendage, and we do this with ultrasound, it's actually not that hard to see. If we don't see any significant leakage of blood around the Watchman, it's doing its job. And that was the endpoint during the study, and it was that endpoint that led to the measurements that showed how effective it was. Can you comment on the use of amiodarone and flecainide? That would take forever. They're both commonly used drugs to help maintain normal rhythm in people with AFib and other arrhythmias. I've used both of them today. I use both of them every day. They're good tools in the toolbox. In most cases, we say that these drugs, amiodarone is perhaps the strongest one we've got. It's also not the one that we love to use forever and ever because the potential for side effects. For most drugs, we'd say your chance of getting efficacy for years is in the 40% to 50% range. Amiodarone might be a little bit better than that, but none of them are 70, 80, 90%. All right, let me see. This might be something a little too specific here. Let me see if I can find some other more general for the audience. Okay, I like this one. Dr. Joyner, thank you very much for your presentation. I'm in my mid-60s and able to control my AFib with medication, flecainide, actually referring to the last question. As I get older, should I consider ablation in case the medication becomes ineffective over time? So that answer is yes. You could be considered good for ablation, but I'll be honest with you that even now, you could get an ablation. So I'm not saying you want one, but let's say that you wanted to get off the medicine for whatever reason, you could be a candidate for ablation, even with what you have presented to me now. So I think both are true. If I was to project, I would say that what you might not want to do is waffle in and out of AFib or use a medicine that has poor efficacy and go year after year, because it seems that the more AFib you have over time, the more your heart changes and the harder it is to get rid of the AFib. So I wouldn't want you going into AFib until you're 80 and then come for an ablation. I think you'd be reducing your chances of a successful ablation procedure. Let's see. Is a regular heartbeat indicative of the absence of AFib? Most of the time, yes. There are some unique circumstances where you can have a regular heartbeat, but it is not necessarily normal. I will give you one example. There's a related arrhythmia, kind of a cousin of atrial fibrillation, called atrial flutter, which is regular. It is usually fast. So if it's regular and fast, I would think of other things, including atrial flutter. And there are some other more unique things that may not be sort of, I'll give one out there as well. If someone has a pacemaker, and I've had this from some primary care physicians, that they'll feel the pulse and they say, well, geez, the pulse is regular. They would like to assume there's no AFib. Well, if a person's heartbeat is now dependent on a pacemaker, the pacemaker will beat regularly, even if the top chamber is in AFib. Pacemakers are designed to do that most of the time. So the presence of an actively operating pacemaker may give you a regular heartbeat, but not tell you the truth about whether there's an absence of AFib or not. Let's see. The question about metoprolol and flecainide and cognitive decline is probably a little too narrow, a little too unique. I think that needs to be directed to your physician that is prescribing those things. That's a very specific question. I think you have to know the doctor and the patient. They have to have their relationship and some time to answer that question. The risk of infection with ablation, almost zero. And I think it's largely because our catheters go in and they come out within the same procedure. So if we have 2 infections at the access site in the groin where we put these per year, that would actually surprise me. When I comment on cardioversion, cardioversion is the fancy name for doing a shock to restore normal rhythm. That's when you come into the hospital. You can come as an outpatient, or we do them even for inpatients. We put you to sleep for a minute. We do a shock that takes about half a second with paddles or patches on the chest. The job is to stop the arrhythmia and allow the normal rhythm to come back through. It usually works about 80% of the time, but the thing for a patient to understand is that that does not fix the drivers of AFib or atrial flutter. So you can have a recurrence. It's not a medicine, it's not an ablation. You can still have a recurrence. We hope you don't have one for a long time, but this does nothing to fix the underlying problem. A question I get asked a lot about Watchman: what happens to the left atrial appendage after Watchman is implanted? Does it atrophy? Is the procedure reversible? Have you done that? Why? Well, it does not atrophy. In most cases, we think that everything in the blood coagulates and seals and becomes sort of thickened, hard tissue. So there's no space left in it. It's not a reversible procedure. Actually, we don't want it to be reversible. We don't want the appendage to be in a position to cause any further issues. So it's considered permanent. Surgeons actually will cut off the appendage sometimes. They will clip it with a device called an atrial clip. They will take suture and like a purse string and close it off at the neck. So there's a bunch of different ways we do this. But in each case, we don't want that appendage to be able to participate in any way after that. Do some of the newer anticoagulation drugs lack a reversal? I believe they are all reversible now. I can't say specifically for Savasa, but the company Portola has made all of the reversal agents for the others. Not many people are on Savasa. I don't know that answer, but I can tell you have reversal for all the others. And then our final question: if ablation fails to cure, is a pacemaker a good alternative? Blood thinner is necessary with a pacemaker. So for some people who we know we just can't stop AFib, usually these are older folks who have had a more chronic course of atrial fibrillation. If they still have issues with fast heart beating that's untreatable or refractory to medicine use, sometimes we'll do a combination procedure where we place a pacemaker, and then we basically sever the electrical connection between the top and the bottom chambers of the heart. And this, I don't know if I can give, maybe I can show some anatomy here to help with that. If we're back on our screen, here's where the heartbeat starts. Here is the middle central portion of the conduction. You can ablate right here, and that stops all signals from the atrium from getting to the large pumping chambers. And we're effectively causing an electrical block there. Of course, if we didn't put in a pacemaker, the chambers wouldn't beat down here. So you become dependent on a pacemaker to control these, which is fine. And it doesn't matter what these chambers want to do at that point, AFib, atrial flutter, whatever, they cannot affect the bottom chambers anymore. And that's an older procedure. It does not stop AFib. It just keeps it from affecting the large pumping chambers. And believe it or not, the vast majority of people who have this ongoing chronic issue with rapid heart rates and AFib feel a whole lot better when we do that. So it's still a very effective procedure. And I think I've got a person scheduled for one of those in the hospital this week, actually. So it still plays a role. And then I guess we'll make this our last question. Is having an ablation more than once common? I think every patient should understand that there's perhaps a 1 in 5 chance that your doctor may have to do another ablation within either several months or years of the first ablation. And of course, you only do it if you've not had a satisfactory result, or maybe your initial result was good, but then you've had some more recurrences. So you'll know just as much as your doctor what comes of AFib and what need there may be for repeat ablation. Usually repeat ablations are not as long as the first ones. We are doing touch-up work in a lot of cases. And once again, things usually get better after that. So we wouldn't do them if there was an improvement. So it's not rare to undergo that. All right, I think that's probably good for us. I probably have overextended my stay, but maybe for those who you're still on, you've gotten some good information. Once again, the numbers are provided. Let me see if I can get to you again here so you can get a hold of us. Maybe it was in the beginning slide. Yeah, let me go back in the beginning and see if we have it somewhere here. We have a number here, and this can get you to whatever doctor you want to see in whatever office is most convenient for you. We've got our electrophysiology or arrhythmia doctors in all these offices, so you should have no trouble getting in to get your condition assessed and to come up with a plan. So I'm going to leave it with that. I thank you for your time. I hope this was valuable to you. I hope it clarified and let you know your options. I'm sure we'll have to do this in another couple of years because things are always changing. And before I forget, it's St. Patrick's Day. Dr. Gilligan is Irish, and there are others who wanted me to put this on, but I didn't have a time for a quick change. But happy St. Patrick's Day, everybody. Have a good evening.